Ashley, why don't you? Perfect, thank you. Well, it is my pleasure to welcome you all to this very important webinar today on teledentistry for people with intellectual and developmental disabilities. And we have three great presenters that you'll hear from momentarily. I'm Gary Harbison. I'm the Executive Director of the Missouri Coalition for Oral Health. We are a 501c3 nonprofit advocacy agency working to effect policy and systems change so that people can have greater access to oral health care as needed. We have some great wins under our belt so far. We got adult dental reinstated in 2016. And right now we are waiting for CMS to approve a state plan amendment change so that the dental rates will go from, for Medicaid, will go from abysmal to basically into the commercial realm. And we really look forward to that happening and moving forward and seeing people get greater access. Again, it's great to have you all here. You can learn more about the coalition on our website. Just look up Missouri Coalition for Oral Health and you can find great things about us. We're on Facebook and Twitter and LinkedIn. And certainly if you're interested in reaching out to us, we'd be glad to hear from you. With that, I'm going to hand it over to Tiffany Grant, and she's going to do some introductions.
Hi, everyone. Thank you for coming. My name is Tiffany Grant, and I am the CEO of Access Teledentistry. And today I'm happy to present our two speakers for this webinar. First, I would like to introduce Kyle Isaacs. Sorry, I have several screens going on, so I'm looking all over the place here. So Kyle Isaacs is an expanded practice dental hygienist working in a variety of patient care settings in our home state of Oregon. She started her dental hygiene business in 2014 and has taken care of low-income patients in local churches, nursing homes, memory care facilities, schools, adult foster care homes, and private residence for patients who are not ambulatory. In 2017, Kyle wrote a proposal for a pilot project to educate the staff employed at long-term care facilities and provide preventative dental hygiene services. She's a published author in the RDH magazine, and was recognized for her dedication to her profession as a 2017 Sunstar Award distinction recipient and a 2018 He3D/ADHA Master Clinician Award. So we're happy to have you and your expertise today, Kyle. I'm going to also introduce Dr. Nathan Suter. Nathan Suter is a teledentistry enthusiast, private practice owner, and chief innovation officer at Enable Dental, and practice owner at Greenleaf Dental Care. He's passionate about solving problems that can help create access to dental care. He began his career in public health, developing programs that served underserved communities. That experience has allowed him to see the gaps in dental care delivery system. He's an advocate. He is an advocate in disrupting the system by leveraging technology and bringing ideas that are outside the box and innovative. He was awarded in 2019 Missouri Dentist of the Year by the Missouri Dental Association. Thank you guys for being here, and I'm excited to hear your presentation.
Thank you. Do you want me to start then?
Yeah.
All right, let me share my screen. Okay. All right. Everybody see okay? Just let me know if not, because I feel like I'm out here on no man's land.
Yes, we can see it great.
Okay, great. All right, so thank you everyone for coming. I just wanted to share, this is one of our ways that we have transported things, supplies, when we go out to different facilities. So I wanted to share with you, a few years ago, I used to work in a corporate office that catered towards the low-income Medicaid population. And at that office, we saw a lot of people that had either intellectual and developmental disabilities. So this one day, I had a patient on my schedule. I went out to get him. I knew he had an intellectual disability, and I knew that he was deaf. And so I went out and I asked his caregiver, how do I say hello in sign language? And she showed me, and hopefully I'm remembering properly, it's hello. And as soon as I did that, his face just lit up, and it made me feel really good. And then the next moment, the caregiver came up to me and she said, you're the only provider that has ever taken the time to try to connect with him. And I can feel it right now, how sad that made me, that he wasn't being heard or seen. So I want to ask you all, have you ever felt like that? Have you ever felt like you haven't been heard or seen? This is what this population deals with every single day. And as healthcare providers, we've taken an oath to do no harm. And what I propose and suggest is that we move past that and deliver compassionate, empathic care, and not only for this population, for everyone. So it's my hope that by the end of this presentation today, that you'll feel empowered to provide compassionate care, for everyone, but especially for the IDD population. And in that same vein, I always like to share a quote when I'm speaking, and this one's from Albert Einstein. He says, our task must be to free ourselves by widening our circle of compassion, to embrace all living creatures and the whole of nature and its beauty. When I was growing up in the 60s and 70s, yes, I am that old, and they did not mainstream anybody who had a disability. I didn't know anyone. I was not exposed to it. That was different for my kids. And I think what happens is when we are not exposed to people with differences than from ourselves, we just have no idea, and it makes it harder to understand. So I'm hoping that you'll learn a little bit more about that as well. And then just a little housekeeping. These are the objectives today. I hope that you can learn, what some of the barriers are for this population, some of the health conditions that they have in the oral disease, how to recognize what's going on in their oral cavity, and then be able to explain the different ways how to provide compassionate care using teledentistry. So why teledentistry? Well, there's a lot of unmet need. And this is just one example of a friend of mine. Her name is Dee. She's an RDHAP in Southern California. She's been seeing a lot of the IDD population. So I've learned a lot from her. And I see a lot of the stuff when I go to all kinds of facilities. We have people who are missing teeth. Maybe they can't eat properly. They're not getting the proper nutrition. People in the IDD population are fearful and have a lot more anxiety than the general population. And I think we can all agree that dentistry does bring up a lot of fears for people. And then we have the mobility issue, wheelchairs. And I'm going to talk a little bit more about that in just a second. If you can all turn up your computer, we've already checked the sound, and this one is a little bit on the light side. This is because I filmed it with my iPhone. So I'm going to start this. Okay. Hi, Maureen.
Hi, Kyle.
Thank you so much for being willing to share your experiences. So, oops. Here I am at your house. I just finished. Oops, sorry. providing dental hygiene care for your son. And so I just wanted to get your thoughts on how that impacts both, you and your son on being able to have dental care at home.
Oh, Kyle, this was such a godsend for us because I've been trying to get Michael to a dentist for 3 years. He's on a high dose of oxygen and is basically housebound. And he has a heart problem, and so gum health is very important. And you did such a fantastic job cleaning his teeth. He was very calm and very happy to have you work on his teeth, and the results have just been great. And I am thankful to have your input on what I should be doing to do better in the future with Michael's teeth. And so thank you, Kyle. This has been a godsend.
Also, I know it warms my heart to be able to help you out, and so it's a win-win.
Thank you, Kyle.
All right, thank you. All right, so that was just one of my patients. You'll see later, share something else with another one. And it's not just me, anybody who just puts themselves out a little bit and cares about this population can really make a difference. So we do have the physical constraints of a dental office. We have wheelchairs. I recently was seeing a patient who has MS in his home, and unfortunately he did just recently die. But I would go to his home because he was in a mechanical wheelchair that was really heavy, and it was just too much for his wife to take him to a dental office. So sometimes it's the size of the wheelchair. It can't go through the opening of the operatories in a dental office. Sometimes it's the transportation can be very expensive. And then it's the transfer, which I'm going to show you. This is my mother-in-law and father-in-law. He unfortunately is no longer with us. That's a Hoyer lift. Most dental offices that I know of don't have a Hoyer lift. They do have them in facilities, and this enabled her to be able to take care of him at home, move him very easily with, not having to use her back and hurt herself, from his recliner chair to his wheelchair to his bed. Well, we don't have those in a dental office. And then there are those that are bedbound. And this is also my friend Dee. And you can see when you do mobile and teledentistry, you are often having to be flexible in your positioning. She's right-handed and doing it from the left side. Sometimes you can move a patient, but obviously this patient is a little bit less mobile. And as I said earlier, we have unmet oral health needs. We have, the stomatitis on the palate. This is a patient I saw in a facility she had dementia, and the partial had never been taken out. And so this is what I saw. And when I was finished, I went up to the nurse, because it was a nurse not a CNA. And I said, "Are you guys brushing her teeth?" And she said, "Oh yeah, we brush her teeth every day." "Okay, great. Are you taking the partial out at all?" And she said, she just kind of looked blank at me like, I didn't know there was a partial. What partial? And so then I explained to them how to take care of it and how and to take it out. And the next time I came back, it was all cleared up, which was great. That doesn't always happen. And then there's other unmet health needs. I've been to facilities where I've seen teeth broken to the gum line, abscesses, all sorts of things. And I'll point it out to whoever is in charge. Could be the executive director, could be the director of nursing or the social worker. And they always look at me with these big eyes like, "Oh my gosh, I had no idea." They didn't complain. Well, a lot of people in the IDD population, they don't know how to communicate that. So we need to work better on that. There are almost 7.43 million people in the United States who have this intellectual or developmental disability. So it's a lot of people living longer, and they have a hard time making decisions without someone and communicating. Maybe it's because they can't speak, or maybe it's they can't formulate in their brain. they can't take care of their activities of daily living, bathing themselves, cleaning their teeth, when to go to bed, making appointments, making meals. And then for some, social skills can be really tough, as you'll see in just a little bit. So people who have IDD do experience more chronic disease earlier than the general population. Epilepsy, infectious diseases, gastrointestinal problems, congenital heart disease, musculoskeletal disorders, diabetes, mental health issues, multimorbidity, Alzheimer's, especially with the Down syndrome population. And because of this patient population is going to experience these chronic diseases. They experience them earlier, and this means they're going to be on multiple medications. So we need to think about that when we're seeing our patients. The woman that you saw in the video, this is her son, Michael. This was right after I saw him. And so I just love this picture because he looks so happy. But the life expectancy for people with intellectual and developmental disabilities is about 20 years less than the general population. And for many, it has actually risen in the past 40, 50 years. For example, people who have Down syndrome, around 1983, the life expectancy was about 25. And now they can live into their 60s. So they're getting these chronic diseases earlier and they're living longer. So they're going to have these chronic diseases for a long time. And for many of them, they're not getting the health screenings that they need. So a lot of their chronic disease that could have been found earlier and treated earlier are going to be much more chronic, difficult, and have more poor outcomes. And not only that, cost more in money. So the National Curriculum Initiative in Developmental Medicine, they have predicted if we have providers who understand and are trained in taking care of this population, that this is how much money can be saved annually, $2 to $7 billion. And I'll share with you a little bit more about why, what happens when people aren't trained to deal with this population. And when you think about how their life expectancy has increased when they were younger, a lot of them were seeing pediatricians or pedodontists who had more training. But general dentists and specialists and regular primary care providers, most of them do not have any training. So they don't understand how to deal with them or work with them. This is another one of my patients, and he has Down syndrome. I haven't seen him for a while, but I always love to see him. He is always very helpful. So oral care or access to oral care for the IDD population is the number one health issue that they face. Part of the reason is because there aren't enough providers. And part of that reason is because they're not trained to do it. The other part is that Medicaid reimbursement is really low. We know what happens with Medicaid reimbursement is people don't, the providers don't want to take it on because it's hard to get paid. And then wait times for appointments can be as much as a year. Or because there are limited providers, the patient and their family or their caregivers, they need to drive several hours each way to find someone who will see them. Recently, with the COVID outbreak, in the height of the pandemic, and with masks, the IDD population was at a higher risk for dying from COVID, and as much as 6 times higher than the general population. And we all know what happens when someone goes to the hospital during the COVID pandemic. No one can go with you. And so this population, if they don't have someone with them, they're going to have a harder time understanding what's going on with them, understanding what's going to happen. Sometimes providers talk way too fast, so they can't understand, and they're not going to get the care that they need. The masks also make it really hard for them. They feel disconnected. There are studies that show that when nurses smile, then patients feel better and they heal faster. So when we're wearing all that gear and the masks and you can't see anything, these patients are missing out on those subtle nonverbal cues. The people in the IDD population also do have difficulty with any kind of change. They like things the way they are. And this is another reason why teledentistry is so important for them, because they can be seen in their home where it's comfortable, where they don't have those awful smells that you get in a dental office. And I already said, communication can be more difficult for them. So I think this is something really important to look at, is about implicit bias. We all have implicit bias, and implicit bias is your prejudice. It's an unconscious prejudice that we all have towards groups. It could be towards someone who has a different religion than you, someone who makes a different amount of money than you do, someone who's a different age than you are, someone who dresses differently than you. Maybe it's the color of your skin, or maybe it's where you grew up, the North versus the South, or the East or the West, or another country. So there are lots of different possibilities of different groups that we can have this implicit bias. And because there are not very many providers who know how to work with this population, what happens is that they feel uncomfortable, they don't know how to deal with them, and they just don't want to. This can happen with other populations as well. And so that's why it's important to have, more Latinos, taking care of Latinos because they can understand, or more transgender people, taking care of people who are transgender. I'm not saying that we're going to have IDD people taking care of IDD people, but if we can know more about how they work, and about their different disabilities, then we can have a better idea of how to take care of them. And unfortunately, the Black and Latino IDD patients are at the highest risk for bias. And what I found really sad and disconcerting was that there is evidence of bias, that providers will make a decision that a person with an IDD's life is less important than someone else's. It's almost like they're triaging and making an assumption. So what we all need to do is to first realize that we have this, and understand that different populations are treated differently. One of the things we can start doing is reach out to different groups of people that are different than we are. Maybe it's someone who's younger. Like, I have a lot of dental hygiene friends that are way younger than I am. And I always feel grateful that they are happy to be my friend. I could be their grandmother. So reaching out to someone who is a different religion than you, or someone who is from a different country, get to know them. The more we can do that, the more we can feel comfortable taking care of them. And like I told you earlier, how I did not grow up with knowing anybody who had an intellectual or developmental disability. Now that I've worked with them, I just love them. They're some of my favorite patients. So you can change your biases and your thoughts and how you react. So what we're going to do now is look at some of the major IDD types of intellectual and developmental disabilities. Some of the more common ones: Down syndrome, fetal alcohol spectrum disorder, which fetal alcohol syndrome is under that, Fragile X syndrome, autism spectrum disorder, and cerebral palsy. And some of those, a lot of times, will also have ADHD, seizures, mental illness, sometimes Fragile X syndrome. That person will also have autism, and it can be a whole bunch of them together. And then also Alzheimer's and dementia. That top photo, it was one of my patients who, I think she was 100 or 101 in this photo. I would go to her memory care facility to see her. So it was very, it was fun to do. So let's look at fetal alcohol spectrum disorder. This one's harder to diagnose. There's no test for it. You have to look at symptoms, facial structure, what's going on developmentally, emotionally, and you can ask the birth mother, but oftentimes they're not willing to share that information. Sometimes. A lot of times you'll have behavior and mental health issues. With fetal alcohol syndrome, they usually don't have a philtrum. Their face is more flat here. They will have a weakened immune system. Mouth breathing is common with almost all of the intellectual and developmental disabilities. And with mouth breathing, often will come a high narrow palate, malocclusion, cross bites, open bites. You'll have more decay in perio because of all that, TMD. And then with the fetal alcohol syndrome, they do partake in pica, and that's where they're going to eat non-nutritive things. Some of them can be hard, so there's the possibility of teeth breaking, having sensitivity, and so it's really important we do assessments. And then people who are born and have fetal alcohol syndrome or fetal alcohol spectrum disorder will also likely have some health issues, heart and kidney disease. Anytime we have any balance and coordination issues with any of our patients, we have to be cognizant of the cords that we have when we set up, so that they don't trip over them. And also when they get up after lying down, that they could be a fall risk. And we're going to go on to Fragile X syndrome. Not sure if you guys have heard of that before. It is the #1 inherited intellectual disability that there is, and it has something to do with the X chromosome. It does occur more in boys than in girls, and boys tend to have more severe problems with it. Sometimes there's quite a range from how independent people can be, and there are a lot that can be more independent than others. And it's also the most inherited cause of autism. And as you're seeing, seizure disorders there's kind of a common thread, and that's something we need to take note when we're going to be seeing these patients. We need to ask them how often do they have a seizure, and when was the last one? The more often the more frequent they are, and the more recent one was, the more likely that they'll have one in your chair or in their chair, wherever you're seeing them. So you need to know what to do in case there is a seizure. And as you can see, a lot of times ADHD, they have multiple sensory issues. So the light, taste. So we're going to think about, what are we using in their mouth? Are we using prophy paste? Are we using fluoride varnish? Are we using our gloves? They'll have a lot of times have a taste. Sometimes the water tastes funny. Sounds. And I'm going to show you some more information later about what you can do for this patient population. Some other symptoms and behaviors that you want to look out on is they will likely have developmental delays compared to other children. And we already said that they have more ADHD, so the hyperactivity, behavior problems, hand flapping, and they usually do that when they get excited. Speaking out. So this is another reason why teledentistry and mobile is really good, because let's say they shout out in the middle of the dental office, they're going to get a lot of stares. And when they get a lot of stares, that causes a lot of embarrassment for the family and the caregivers. But they are really good at visual and long-term memory. So I highly recommend using pictures and photos and diagrams and things that they can look at, maybe to explain what you're going to do. And as I said earlier, they'll have a heightened sensitivity to any of the 5 senses. Anxiety is high, of which we already know that dental care can be a big anxiety producer for a lot of people. And because of the ADHD, they might have trouble paying attention to you. And so with them and anybody else, you might want to, let's say you're scaling the teeth, you're going to go, you can count out loud and you're going to scale 3 teeth. Okay, now 1, 2, 3, take your scaler out, have them close. Good job. Pat them on the shoulder. Positive reinforcement is so important for all of our ITD population. They are less likely to make eye contact with you. It's really interesting. I had not off topic, but this week I had one patient with autism in the FQHC where I work and one with Asperger's, and neither one of them brushes their teeth. So it's going to take a little work getting them to do oral care, but neither one of them likes to look at you in the eyes. So knowing that they're not being rude, but it's uncomfortable for them, and just being cognizant of that can be really helpful. And they can have a hard time communicating. So you just have to be patient and kind and compassionate. Some of the things you'll see intraorally, you'll see pretty much with a lot of these IDD patients, high vaulted palates, which is really common with mouth breathing. When people mouth breathe, their tongue is usually set low, and the tongue needs to go up into the palate to help shape it. And that can be from habit. It can be from a restricted tongue from their frenum. And that also increases crowding and malocclusion. Microdontia is often common, and macroglossia, although a large tongue, not necessarily that it's large, but that it looks big because the jaw is underdeveloped. So is it really a large tongue, or is it just because there's not enough space? Supernumerary teeth are common with them, and the open bites and cross bites, and they will have low muscle tone. Now we're going to go on to Down syndrome. I'm sure everybody has known or met someone with Down syndrome, at least by now. Common with them is torticollis, and torticollis has to do with the sternocleidomastoid being tight on one side. And so they'll be more pointing to one side, have a harder time when they're babies, turning. Sometimes it can be during birth, or apparently a smaller uterus. It can also possibly be from a tongue tie. And so they can have neck pain. And interesting to be aware of that. If they do have torticollis, you might want to see about them getting some body work, cranial sacral therapy, massage, maybe if they can tolerate that. But we have to think about how we're taking care of these patients. And if we say, turn towards me, and they just can't, then we might need to accommodate our positioning to help them. They do have immune deficiencies, so they're more susceptible to all kinds of things. Obstructive sleep apnea, which raises their risk for diabetes, GERD, high blood pressure, heart disease. Obstructive sleep apnea can be tougher to deal with someone with Down syndrome because they're not always open to treatments. So they got acid reflux, sinusitis. Oops, I'm going to have to fix that one. Nasopharyngitis, enlarged tonsils, which there is controversy whether mouth breathing actually can enlarge those tissues, but that could be a possibility. General anxiety again, OCD, depression, autism, another one, and Alzheimer's. By age 50, about 30% of the people with Down syndrome will have an Alzheimer's-like dementia. and by age 60, about at least 50%. So that's huge. And congenital heart disease and defects. So you can see this is just some of the health issues that people with Down syndrome can have. So they may be on multiple medications. So we're looking at dry mouth, we're looking at all kinds of possible side effects, and think about when we're doing, if we do need to do anesthetic. And hearing loss. And hearing loss is really important to remember, because especially with the masks, and if you're wearing a mask or double masking and then the face shields, they're not going to be able to hear you. And so we need to remember that if they don't respond, it could be partly from that. I just wanted to share an interesting story. I found this photo on a blog and I emailed the person who wrote the blog, because I never use anybody's photo without permission. And I said, "Hi, I'm doing this presentation. I found this really cute photo of your daughter. Can I have permission to use it?" And she wrote back, and she said, "Oh my gosh, I'm so shocked that you would ask." And so she was excited that I was going to be using it, and thankful that I had asked her. So yeah, the teeth erupt much later for people with Down syndrome. In 2 years old, so a good year after most kids have their first teeth, and they don't get all of them until 4 or 5. So, a good 1 to 2 years after most kids in the general public get all their teeth. And then you can see eruption of number 24 and 25, and the first molars is much later as well. Oftentimes, people with Down syndrome are also missing teeth and have impacted teeth. They have shorter roots, so they don't have as much to work with. They can't afford to lose much bone. Periodontal disease is pretty common. The fissures on the tongue are more likely to trap bacteria, which we know can affect the overall health, oral health. And again, microdontia, macroglossia, they have the small maxilla, the vaulted palate, peg laterals, open bites and cross bites. So you can see that different intellectual and developmental disabilities will have some of the similar things going on in their mouths. In the past, when people were institutionalized, and there were a lot of people with special needs and IDD community who were institutionalized, the Down syndrome people did not have a lot of decay. But their diets were closely monitored. And so I would not assume that they're not going to get cavities, because things have changed since then. Also, what you'll see common with Down syndrome, you can see how that tongue on that little baby is sticking out. That's part of that low muscle tone. And so their tongue is sticking out. And probably when they swallow, they have that tongue thrust swallow rather than going up to help shape the palate. So you're going to continue to get that narrow palate, which can affect breathing and can increase obstructive sleep apnea. So yeah, they have bruxism, they can have TMD, and periodontal disease. So with their weakened immune system, that's going to affect them even more. The other thing we have to consider with Down syndrome, about 10 to 20% of them will have the atlantoaxial instability. So that's looseness in the C1, C2 area, which means their spine, the nerve is much more susceptible to being hurt, and when we're working on them, so we don't want to do any neck extensions. This is not a patient with Down syndrome. This is a patient with dementia, but this is at the Veterans Home where I see patients, and I was working in the salon. We now have the old gift shop, and we now have a dental chair, and they have a Hoyer lift there. Sometimes I still see people from the wheelchair. This wheelchair headrest wasn't the best, so I always put a pillow there. So you might need to use a pillow behind their neck, but whatever you can do, you want to be careful. When you're working with this population, you can also ask their care their providers or their caregivers or their family if they've ever been checked for it, because sometimes it can be fixed. And I know ergonomics is not great when it comes to doing mobile dental, as you can see in my position there. So let's talk a little bit about autism spectrum disorder. And I'm sure everybody has met or known someone with autism. There's quite a range. And from what I've read, people in the autism community, they really don't like to be lumped in with anyone having an intellectual disability. But we know there's a big spectrum from those who can live independently and do just fine to those who can't. So they'll have problems and issues with communication and social interaction. That also can have malocclusions and crowding, open bites, and poor tongue coordination as well, which is probably contributing to the malocclusions, also probably higher and narrower palate because the tongue is not getting up. And then other things, the tongue thrusting, bruxism, and lip biting. So when people with autism spectrum disorder come to see us or we come to them, they can be challenged with the treatment. They're hypersensitive to all the sensations. So are you going to polish their teeth? Maybe they don't like having their teeth polished. Do you really need to polish their teeth? I mean, is that really therapeutic? With most of my patients, when I go mobile, maybe you guys don't agree with me, but I will pre-brush with a toothbrush dipped in some kind of antimicrobial. I really like Closis because there's no alcohol and you can do it without any flavors. So it's chlorine dioxide. And then I'll also oftentimes use proxy brushes, whatever I can do to clean before I do any scaling. And most of the times I don't polish them. I know that sounds like against everything that you've learned, but maybe not doing that polishing might be what's good for them. You know, maybe that will help them enjoy the appointment better. Can they tell you what's going on? Can they tell you if something hurts? Can they tell you if they need you to stop? I always ask my patients to please tell me if they need me to stop or if something hurts to raise their hand. I just had one yesterday and my patient with Asperger's. And it wasn't anything that was bothering me. He had to cough, but he did it. I stopped. And in my trauma course, I talk about that because trauma patients need to have the ability to feel empowered and be heard. And sometimes they have difficulty managing their emotions. So again, going to someone in the place where they live is going to be much better and less embarrassing for everybody if you're not out in the public where all of a sudden they have an emotional outburst. When I go and do mobile dentistry and teledentistry, I can stop what I'm doing, not worry about when I'm getting my next patient. I can give them time. They need patience. We need to give them time to process things. Don't feel like you have every hour you have to get to people. So here are some good pointers that can help you. Make sure you explain to them, but say their name. Hi, Mary. You've already introduced yourself. Mary, I'm going to look in your mouth right now. Can you open for me? Mary, I'm going to put this mirror in to look. Would you like to hold it and try it? And then, like I said, give them time to process. You have to be patient. People with autism, they don't understand joking and metaphors and body language. They're very literal. So it's recommended not to use those when you're trying to communicate. Just be straightforward with what you want to say. So we're going to go on to cerebral palsy. And I have 3 listed here, but really there are 4. The 3 of these mixed together, sometimes people have a combination, creates the 4th. So we have the dyskinetic. So this patient will have difficulty controlling movement, all different parts of the body. Ataxic, problems with balance and coordination. And in a little while, I will share with you about the spastic. So I want you to think about when you're hearing about the cerebral palsy, how you might have to adjust your appointment. Some of the health issues, mouth breathing and drooling. So you're out in public, you're in the dental office and they're drooling all over the place. They're going to get stares and we don't want them to feel uncomfortable. Crowding and malocclusion again. Perio and gingivitis. I think you may be seeing that there's a connection here that a lot of these intellectual and developmental disabilities have very similar health issues, have very similar oral ramifications of how things look. Anybody who takes longer to eat their meals is going to have a pH that's lower for a longer time, more food in the mouth, and so more chance of having cavities. They're more common to have GERD. They pouch their food. People with dementia do this often as well, which means more food in the mouth. They're more likely to vomit, which means more acid. So you can see there's a theme there about more tooth decay. They will bite a lot of their lips and cheeks. They do have bruxism and seizures, more often to have problems with gagging, choking, and aspiration. A lot of the times when I go out and I do mobile dental hygiene, I don't use the ultrasonic because a lot of my patients have choking problems. I would recommend, if you feel like you need to, that you, one, have an assistant helping you and maybe use a piezo instead of an ultrasonic where there's less water. Muscle tone can change from very tight to very loose day to day. So you never know where, their hands might be going and their head and the tongue when the tone becomes more stiff and more, and then flaccid, and then stiff and then flaccid. And then a lot of times we have to think about, how is medication given, especially for little ones. If it's given in liquid form, it's likely to have sugar in it. So if you can have them rinse afterwards, that can be really helpful. With cerebral palsy, there are involuntary body movements. So if you can see and think about doing dentistry on this boy, you're having a syringe with a needle or an instrument that is sharp and their head's moving around, you're more likely to hurt them or yourself. So you're going to need assistance, 1, 2, maybe even 3. And I'm going to show you in just a minute what that would look like. The hypertonic tongue. So the tongue is going to be extra strong. The ataxic cerebral palsy are more likely to open excessively wide. So maybe you're trying to work on the buccals and you can't because they can't close. And then really, really helpful to allow for extra time and frequent breaks and explanations. This is my friend Dee again. As you can see, she has 3 assistants. One is holding the hands and the legs. One is holding the head. And one is helping her, we can't really see, but probably holding a mouth prop. And I'm going to show you later a few different kinds of mouth props. This is called spastic quadriplegia. It's a type of cerebral palsy. The muscles are stiff and they have jerky movements. It can affect the whole body. So really important to have an assistant holding a mouth prop in there to help keep the mouth open, someone holding the head. These patients also have a higher risk for epilepsy, hearing loss, vision impairments, and the intellectual and learning disabilities and osteoporosis. So with that, we know that bone loss increases periodontal loss and tooth loss. And they are more likely to have pressure sores. We're going to move on to Alzheimer's and dementia. I have seen patients in facilities who've just come and how fast their oral health goes downhill is just crazy. And maybe some of you have seen that in dental offices where you'll have someone come from a facility and you just see all this food debris and biofilm and, and all this stuff on their teeth. And you're like, why isn't someone taking care of them? Well, first of all, people, the CNAs are overworked and underpaid, and they don't have the training, and they don't feel comfortable. The other thing in facilities is if someone refuses, they're not allowed to force them. And I say force them because there's a difference between forcing and feeling comfortable providing oral care. And I think that's really what it is. If you ask someone with dementia, think about a 2-year-old, do you want to brush your teeth? What are they going to say? Probably no. So instead, you can try something different, like, would you like to put your pajamas on first or brush your teeth first? Or, something like that. Or you can walk out the door and come back in and just do it all over again because they won't remember. A lot of the CNAs, and not all, but a lot of them don't have access to good dental care either. And so a lot of them have poor oral health. This is one of my dementia patients. This is what I saw every time I went to see her. One time I was there, and it was right after lunch. I was setting up in her room, and I saw the CNA hand her electric toothbrush and then walk away. So who knows what she did with that toothbrush? She could have used it to clean the toilet, or she could have put it in the garbage, or she could have, who knows? So they're not getting the oral care they need. And another time I was in a facility, and I had one of the CNAs hold the hands of my patient while I was brushing her teeth. And literally, this is what she was doing. She could not deal with seeing what was in the mouth, yet they can change diapers. So, that's a whole nother tangent that we need oral health people all the time in facilities. So let's look at some of the medications and some of the side effects that I'm not doing specific medications, but the reasons why people would have medications. They have them for seizures. We know what, and you'll see the side effects down here. For aggression and depression, muscle spasms, or spastic quadriplegia probably will need medications for muscle spasms. A lot of them have sleep issues and Alzheimer's. Anxiety. So some of these medications are going to create dry mouth, cardiovascular disease. So we're going to see more inflammation, medications for diabetes, gastrointestinal problems, mood, ADHD, spasticity. Some of these side effects are going to be vomiting, xerostomia, orthostatic hypotension. So we have to be careful when our patients get up after lying down. Irritability. Some of these patients already have irritability. So we want to be really careful. I want to just share a little story from my friend. She was taking care of some people in the IDD community. She was at a facility. She was working on this patient, and apparently there was going to be an outing. And there was a bus coming to pick people up. Someone who worked at the facility said, "Oh, the bus is here." And the patient that my friend was working on was upset because she was going to miss the bus. And she bit my friend's hand, and she had to go to the hospital and get stitches and went almost to the bone. So we have to be really careful and let the staff know not to say things like that, because they can all of a sudden bite down. I've been bitten as well. Insomnia, medications for side effects, sedation, restlessness, loss of coordination. So again, we need to make sure that that person can walk, if they're a walker, safely. They'll have fatigue, so maybe that'll affect their oral hygiene. And then the gingival hyperplasia, which we know comes with a lot of the seizure medications. Tardive dyskinesia is where you have all of a sudden movements like maybe eye blinking or sticking out the tongue, things like that. Anxiety. So what we need to do is ask. We have to ask a lot of questions. And I have had experiences where I didn't ask enough questions. I was at an adult foster care. No, it was a daycare, adult daycare, where people with a wide range of disabilities would come. So one time I saw this patient, I did just an assessment, and after he was finished and gone, the nurse was in there with us and didn't say anything ahead of time. She says, "Oh, I was surprised how well he behaved. Usually he is combative." I'm like, how come you didn't tell us that? So ask as many questions as you can. Uh, Understand what their mental health issues are. Understand if they have a history of, being combative and hitting or spitting or biting. And then also on the other aspect of it, do they consent for themselves, or does they need a POA? Will they cooperate better with a caregiver in the room with them or one without? Are they biters? This is a tool that I'm using. You can use a mirror as well, but this is something I have, actually inexpensive mouth mirrors that I will leave with the facilities that they can use to in the cheeks so that they can get the toothbrush in there and see. This one is from Armor Dental. I don't know if anybody knows Cherie Lepensk, but she invented these. They're for usually post-surgery to cover the surgical site so that people can brush their teeth without hurting a surgical site. Ask how do they normally cooperate? Any other behavior issues you can think of. And then, do they let you provide oral care? And if not, what do they do? Do they just not open? And I'm going to show you a little video in just a second. So will you be using a chair like this? Or will you be seeing them from their recliner or their bed? I've seen a lot of patients in their bed. Especially if they're older, they're going to need more comfort. This is not very comfortable for someone who has a lot of back issues. You can put pillows down there, but I always try to find what's the most comfortable for them and at the same time is comfortable for me because, longevity as a provider. We already touched upon some sensory issues, so find out if they have taste issues and if you're going to use or not use paste. And like I said, the gloves, the hand sanitizer. Does your sanitizer have scents in it? If you can get something that's not scented. Lights, maybe I always have my patients wear safety sunglasses, but maybe a towel over them. And then do they like to hold something? My patient that I told you about at the beginning, that was deaf and IDD, he liked to hold a hand mirror. Well, you don't know unless you ask. Maybe it's a stuffed animal, maybe it's a toy. Noise canceling headphones, or maybe they like to listen to a story. Ask them what's helped in the past and what makes them comfortable. And best time of day. This is really helpful with people who have dementia. The sundowners, certain times of day aren't good for them. Some of them, early mornings better. Later in the day, they don't cooperate as well. So always finding that out can be really helpful. And then I think we talked about that a lot. You can ahead of time maybe get them a mouth mirror or have them get one, let them practice at home, opening their mouth, practice holding the mirror in their mouth, anything you can do to have them practice ahead of time so that they're more comfortable and opening wide and closing. If you do polish, cordless polishers are quieter than a corded one. So you might want to think about doing that. And I find when you're out mobile and doing teledentistry, it's much easier to use a cordless one because you don't have to worry about sterilizing. Frequent positive reinforcement. You're doing a good job. You're doing so great. Wow, we did 2 more. Look at you. Giving them lots of breaks. Maybe there are going to be some rewards. Maybe it's something just really tiny. Rewards can be very helpful. Like I said earlier with the Fragile X syndrome, they're very visual. And so, photos of the different things you will do, let them see and touch the instruments. And shorter appointments, start with something really easy. Maybe they need to desensitize, where you just come and you meet them. Maybe you come and you just have them open their mouth. You'll have to be the judge of that. And then with some patients, especially like with autism and some IDD patients, you'll have to say, I need you to look at me right now. And this is what we are going to do. The other thing to realize is that just because someone is not verbal does not mean that they're not intelligent. So always take that into account and talk to them like you would talk to anybody else, using a normal voice, and repetition really, really helps. I'm going to play this video. This one you should be able to hear. This is a little aid that helps with, it's like a mouth block, but it also has a handle, and you would definitely need it. Well, I would think you would need an assistant for this.
Another device that may be used is a simple mouth prop with a curved handle for control. The mouth prop helps assure that the patient does not clamp down on a dental instrument or the practitioner's fingers while the dental treatment is being delivered, and the handle helps the dentist to keep the mouth prop in position.
Or your assistant.
For control, dental instrument, and the
All right.
for control on a dental instrument or the practitioner's.
I need to figure out how to get to my next screen. Just give me 1 second. Oh, there we go. That one is from the Specialized Care Company, as well as this one. And so I wanted to share these with you because they can be very, very helpful.
Hi, I'm Liz, and I'm going to show you the difference between the regular and thick open wide mouth rests. Both are made with a high density foam and a rigid wooden core. That makes them very comfortable, yet also effective in keeping the mouth open, either at home when you're brushing someone else's teeth or for disposable use in the dentist's office. The outline is exactly the same for both. The difference is in the thickness of the foam. The regular mouth rest works for just about everybody. The thick mouth rest has 40% more foam to withstand aggressive biting pressure. That's it for now. On behalf of Specialized Care Company, thank you for your interest in the open wide mouth rest. Open wide the mouth use in the dentist.
Sorry, I don't know why.
The thick mouth rest has 40%.
Oh, okay. So I don't have any connection with that company. I just know that they're very helpful. I'm going to share with you some other options. If someone's going to do it for themselves, you can put a toothbrush in a handle like this, or a styrofoam ball. You can take a tongue depressor and wrap it with a whole bunch of tape also as a mouth prop. This one on the left is the Collis Curve, and that's the Perio triple toothbrush. Then we've got the Dentrust on the right. I like the Collis Curve better. I've used both. I like long-handled proxy brushes. On the right is another one of my patients at the Veterans Home, and she would not open. I did not have one of those mouth props. I couldn't get a regular mouth prop in, and so I would use the handle of the toothbrush to keep her open. Now I know about these others. We have to remember to be flexible where we're going to see our patients. This one in the middle is a dementia patient that I saw, and I had to see him from that side because the bed wouldn't move and he would not move. Because I've had them put their head at the foot, and so then I could see them on the side that worked for me, but he was not wanting to move. Always, be careful of your ergonomics. And so we do have to be cognizant of that and take frequent breaks. So we're going to give our patients frequent breaks. We give ourselves frequent breaks and just put our shoulders back and stretch for a second. And I want you to remember, don't ever get upset if someone says something mean to you. It's not personal. And always remember that you're going to do the best you can and let go of what you can't do, or what you know and think. Like, are you going to be doing crowns and bridges and implants in these patients? Probably not. Maybe a crown, but are you going to be, maybe you'll be able to do scaling and root planing. Maybe they'll have to go to the hospital for that, but you're going to do the best you can. Because teledentistry allows for all people to be treated like in a compassionate way, especially when they're drooling or making noisy sounds that draw rude stares that can be hurtful. This is a letter that I got from one of I think she was the niece or a friend, I can't remember, of one of my dementia patients. And that's what we're doing here, is we're making a difference in someone's life, as well as taking care of their oral health. And that's what all I have for you today. So thank you so much. So I was wondering if anybody has any questions.
Okay. If there's not any questions, we have a small presentation from Dr. Suter talking about kind of bringing these two subjects together and talking about the evolution of telehealth systems within this population. So if we don't have any questions, I'm going to go ahead and let Dr. Suter get started.
Thank you. I actually have a question, Kyle. When you're doing teledentistry for this population, is it do you get much teledentistry between like the patients or the caregivers having questions for you, and it's like triaging, or is there other forms of teledentistry that you?
So I've done it in a way, the way I've been doing it has not been traditional teledentistry, because I've had a hard time getting people on board. So usually what happens is I will, and we don't have any mobile dentists in my area. The only mobile dentist in my area works for a company called Exceptional Needs Dental Services. And he will see the patients in facilities. If I have a private patient, he'll see them only if they're in a facility. He won't see them in a private home. So there is not one in my area. Up in Portland and Salem, yes, and but so he is in my area, but only for the Medicaid population, or if he's already going to that facility. So I have tried to get them on board with doing teledentistry, because my thought was, I can take x-rays, I can share with him my information so that he can then come and do his exam. I mean, the exam's already done, then he can come and do the treatment, as opposed to coming, taking some x-rays, then coming back a different time. The teledentistry just makes it more streamlined. With my private patients, then what I do is I share my information with their dental providers, and some of them do end up going and some of them don't. So there is definitely a disconnect in my area for those who can't physically go to a dental office. So having a dentist come is really crucial. So what I've been doing is a lot of silver diamine fluoride.
Mm-hmm. and that's because you can do silver diamine fluoride in the cleaning. And what other services are you able to do independently without a practitioner?
I can do local anesthesia as long as I have a collaborative agreement,
Okay.
which I do. I don't need a collaborative agreement to see patients. I can do assessments, screenings, fluoride varnish, all the dental hygiene services, the SDF, yeah. And in a lot of different settings.
Great.
Sealants
And
too.
sealants. What about so if you see a patient and they need care and you get them, at least provide information for their regular dental home for treatment, or if they don't have one, maybe guiding them to one.
Yeah.
How do you does that kind of passing of the torch kind of look like usually of the care? Is it like they get a copy of your summary or some sort, or is it you send your full-blown x-rays to that provider? Or
So
like,
I don't take x-rays.
okay, you don't. You could if you were connected to a doctor, or you just don't.
I could, but I don't have a sensor and a Nomad. They're quite expensive.
Oh yeah, for sure. Absolutely.
So I make my referrals. I write up a form that I leave with my notes of what my recommendations are, what I did that day, and I give it to the caregiver or the facility, or it depends on the facility. So if I go to a private home, I give it to the person who is taking care of that person. And then I also will send a letter through a HIPAA compliant email that I have, Speeda Mail, to the dental provider saying, I saw so-and-so on the date. This is what I did. These are my concerns. I recommended that they come and see you.
Great. Do you provide any photographic imaging when you do that in your emails?
Sometimes.
Or not? Sometimes.
Sometimes.
I will argue that is teledentistry.
Yeah. Okay. Yeah.
I would actually be very much. I would stand right next to you saying that's teledentistry.
Okay.
Even though that there could be more gain there by, x-rays and things like that, if you could find a provider that was willing to make that connection a little more established. But that's really neat. And then with teledentistry, for this group, you were showing, or maybe that was your friend in California that was sharing those photographs. Do you get patients that you serve where they send you stuff like, hey, I saw this thing? Do they ever do that kind of patient to you kind of communication?
You mean a facility? Like a facility?
Yeah, either a facility or a resident in a home that is your patient, throughout the year to date, to send you photographs
Sometimes.
or stuff like that. Okay, great.
Yeah, or I'll get a message, an email, or a telephone call.
Okay.
Yeah.
Okay. Well, I would again say that you're definitely doing more teledentistry than most people, honestly. So thank you for sharing that, for all your slides and your examples of these cases that you're seeing every day. That's really, really great work. Thank you for sharing that.
Oh, you're welcome. I just want to share that at that facility that I go to, the adult daycare, we haven't gotten back in since the pandemic, but
oh no.
One time I had a patient, and again, they didn't tell me anything, and I'm doing my oral cancer screening. I'm like, this is so strange. What's on the palate? The soft palate. There's hair growing out of the soft palate. Like, oh my gosh, there's some kind of a cancer, a tumor or something. And I just had no idea. And then later, the nurse again told me that this is a guy who tried to kill himself by shooting up through his mouth. And so they had transplanted like skin from, I don't remember where, if it was his leg or arm. And so that's why there was hair growing out.
Wow.
Yeah.
That's a crazy story, unfortunate story. But like, I don't know if I would have drawn that connection very easily. I would have been stumped.
So Molly, who was with me at the time, she's an assistant, but she's also our director of our dental stuff, but at the time we were smaller. And I'm like, my eyes are looking at her like, Molly, I don't know what this is. And she looked and like, we don't know what this is. And the guy couldn't tell me, he,
Mhm.
wasn't able to explain that. And then another time, and this is just a shout out to all of us hygienists. I had a patient who had an abscess on, it was either number 8 or number 9. And so I said, we recommend you go call your dentist today and get seen. That patient had just been to the dentist that morning for an exam and it was missed. And this just brings us back to, I don't know whether they just really quick because it's a special needs patient and they thought that whole scenario of they're just not as important. I don't know. I can't make assumptions. Or did they just really miss something big? So I just wanted to throw that out there.
That really paints the example of why it's so important to I always Tiffany works at my practice with me, and she spends way more time with the patient than I do, so she always is able to point me in the right direction quicker on the things the patient was chatting with her about, that was bothering her or something she noticed more because she was in there, cleaning their teeth for some,
Right.
longer period of time. So that's
That's
very
that's
important.
definitely true.
Yeah, that's great. I'm gonna pivot over to it's just one little presentation or slide. Gary, go ahead. Sorry.
Yeah, I wanted to ask a question. You said a minute ago that there's a facility you were in before and you haven't been able to get back in since the pandemic.
Mhm.
Is that big? Why is that? Why is that?
So we will, but we've gotten back into one facility, the Veterans Home. I started back there almost a year ago. I think it's just more of us getting organized and finding time that we can do it because I'm busier now. So finding time that I can actually get there. And so it might be that we need to hire some more people to make that happen.
Well, and sort of related, thank you. And sort of related to that, do you find there are facilities that just don't want you in there? Period. Have you had that type of experience?
I haven't found that, but I have found that some facilities are definitely more open to working with us. The Veterans Home being one of them, and that adult daycare, another one. There's other ones. I think that they just had too much chaos, too much drama, too much stuff going on that it was just hard for them to think about us being there. But for the most part, everybody's been pretty open. There was one assisted living place I was going to go, and it never happened because of I went to have a meeting with the person, and I got there and she had to reschedule, and then, just constant calling. And then there was one place that didn't want us to come because I'm trying to remember, something having to do with something that happened in the past where they got in trouble for something. And so they were being really, really, really careful legality wise. So we never ended up going to that one.
Okay. Interesting. Well, thank you.
Yeah.
That's probably a whole other discussion, but we'll let this move on. Thank you.
Well, I'll go ahead and share my screen. I just have one slide just with some talking points. And then we can open it up again if anyone has any questions or thoughts on the topic. So I'll switch over to that. Great. So I just wanted to wrap it up with a little bit about the telehealth aspect of reaching this vulnerable population. And there's a long history of telehealth in this setting. I mean, we were doing some research for this, saying that, you know, back in the 1800s, when the telephone was invented, people started finding that, you know, using communication was a quick way for doctors to start diagnosing and triaging patients to be more effective. It goes all the way back to just those early innovators, even with the telephone. And then this population has usually been managed, you know, through episodic care and using the office-based model. And we found that even in Missouri. So we've been starting to work with Gary's group at Enable, has been working with Gary's organization to reach out for a pilot with the Developmental Disability Council. And we were struggling to find some of, you know, we're calling these organizations, and sometimes it's hard to get to find out that they even want the services, even then we're offering it. And what we're finding is that dental care, these the caseload of some of these HCS facilities is so bogged down at the case management level that it's very, unless it's like a limited emergency, it's out of sight, out of mind for most of the case managers. And so we're having a hard time convincing some of our large HCS providers in these communities, in these regions, to accept the services, because they just assume nothing's bothering anyone. We don't need to worry about it, when we could see in those photographs that that's what's going on when you actually like pull their lips back and look at stuff. And so, and we also know that the need is there to establish preventive care to this population that has not been served well by traditional dental offices, and using teledentistry and a mobile method to bring to them is very much needed. And the validation that we've gotten is there are some HCS providers that, once they find out that we're doing it and they have the right people in place that are in charge of the care of these people, that value that, they want us to see all their people and kind of like get them into regular, you know, preventive cadence, you know, getting them taken care of. And traditionally, whether Enable's seeing them in Missouri, or we're seeing them, you know, in Texas, where we see a lot of these patients, they're not they're not really heavy utilizers of treatment. They skew to kind of more preventive care in some of the needs when we look at the other patients that we serve, that are patients that do not have intellectual disability or developmental disabilities. Those other patients have more treatment that they either ask for or they need because of their past history and diet. And so that's kind of one distinguishing factor, I feel like, with this population, is that they need the preventive care, and this delivery model can get that to them faster if we can convince the people in charge of their care to kind of, you know, get them to see the value of it, and not like Kyle was saying, they don't communicate very well. And the general population, the biggest motivator to fill your schedule for a percentage of dental offices is pain. And a lot of times they can't even communicate that to people. So again, use of technology for disease care management has helped with better outcomes, and it can help this population as well. So doing more telehealth services can let us intervene, you know, find things faster, identify the problem, and get them into care quicker. And there's been really good developments in store and forward technology that can help for things just like Kyle was talking about, either patients sending them photographs or or she's like gathering this diagnostic data and sharing it with the community providers so that they can maybe say, oh, here's not just a slip of paper saying they need to see, but here's also the pictures showing you that how urgent it might be, or how bad of a condition it might be. Some of the things in the future that I think we should consider for telehealth is building upon our clinical expertise in this area. And that is why I think it's important for Kyle's presentation to start the way it did, because we don't have a lot of clinicians that serve this group. And the more we can bring clinicians in that know how to speak about this group and identify the difference, we struggle interviewing providers all the time for these positions, and trying to weed out the providers that don't get it or speak about this population in a way that they're not going to provide probably the best care for them. People that come and think that they're donating, they feel like it's a non, like a lesser service, and they in interviews come to you and speak like that, like, I'm gonna give back now and maybe do something. And if they tell us that in an interview, for example, recently, this person's not gonna make it past the next interview phase, they said, well, sometimes I just need to get out there and get this person their tooth, they just need their teeth brushed. And that's not really yes, that sometimes is the only thing you can do. But if that's your mantra, then you're probably going to miss the abscess on 8 and 9, like Kyle was talking about. Like if you just view them as patients that are, you can give a percentage of your clinical expertise to, but that's a problem. So I think that this really is a good example of how we can use technology, reach these people, have really innovative ways to have hygienists go out into the community and provide really good care to these patients, using evidence-based standards, and using the newest technology to reach them, and try to create a new way to find these patients that just aren't in your regular patient base. But like Kyle said, there's 8 million of these patients living amongst in our country, and they're not represented in the national record of patients that like get seen through the regular delivery system. So anything we could do to figure out innovative ways to reach them is going to be very helpful. So with that, any other questions or comments? I'm happy to keep going there.
Anyone want to chat? I mean, you can use the chat box, or you can ask any questions. I don't know if it like speaking won't be enabled or anything like that, right, Gary or Ashley?
We can do that. If somebody wants to talk, we can. I think Ashley's ready to open the mics.
If you have a question you want to ask live, just type in the chat box that you have a question to ask, and I will unmute you.
Okay, I think we may be good then. I think for our enabled participants who might get in the chat later, just know that we can forward you Kyle's information, or we can, and I'm sure you know Dr. Suter's information. If you have any further questions about the presentation, or you have any more questions, you can feel free to reach out to Kyle, Dr. Suter, myself. And with that, I'm going to give it back to Gary to close.
Yeah, well, thank you all very much for being here, and really an outstanding presentation. I really appreciate the expertise. And I did want to note through a screen share that funding in part for this comes from the Missouri Developmental Disabilities Planning Council. And note the act and the law there. They are grant funding the project we're doing with Enable, and so we wanted to be sure and mention that here because this is very much related to that. So I don't know if there are no other questions. We can probably say goodbye to everyone. Does any last minute comments? Again, we'd be glad to take you off mic and let you jump in there. Any inflammatory comments anyone would like to make? Accusations? You got a thank you, so that's good. Well, thank you all very much for being here. Thank you for the excellent presentation, and we hope you learned a lot. And for those of you who are watching the recording, try to attend live next time if you can pull it off, because it's better that way. But I hope you find the recording helpful as well. So I think we can tell everybody goodbye. Thank you so much. Have a great afternoon and evening.